Okay, so good evening, everyone, and sorry for some time delay, which was unavoidable because there was some new system with me and I had to work it out. So compared to last time, what we had a very interesting topic on amputations in orthopedic oncology, where we learned different principles. So today we are going to discuss about hemipelvectomies. This is a very broad topic, and by hemipelvectomy, we means resection of the pelvis. It may be done in various circumstances. Different types of hemipelvectomies are there, and I've tried to put up my cases, which I have operated myself, to put in as an example. And I would prefer if you have any questions, please feel free to interrupt and ask because I don't want to be just a lecture and presentations. You have any queries, any doubts, please keep asking in between. I'll be happy to take on the questions. So if we talk about the tumors in the pelvis, uh, pelvis is not the most common site. The most common site of bone tumors is distal femur, proximal tibia, upper proximal humerus. Pelvis, the primary tumor like osteosarcoma, Ewing's or chondrosarcoma, they constitute around 10% of their incidence in pelvis. When we talk about secondary tumors, which means the tumors which spread to other parts of the bone, then spine and pelvis are the most common sites. And you know, more than 60% of the carcinomas, they have a tendency to metastasize in their natural course of disease. Which are the most common site of tumors that metastasize to the bone? This is also a favorite question by the examiner. So you must know from top, you have thyroid, breast, lung, kidney, and prostate. These tumors, they commonly metastasize to the bone. When we talk about pelvic surgeries, broadly, there are two types of surgeries. One is external hemipelvectomy, which means it is a type of an amputation where we remove the part of the body, we chop it off. The other is internal hemipelvectomy. This is much more complex, and this is something like a limb salvage system, where we preserve the limb while we remove the part of the pelvis and we preserve the limb. So we'll see how and what it means. Prior to that, let us see what are the indications where we plan pelvic surgeries or pelvic resections. So we know most common like malignant bone tumors, like I said, osteosarcoma, Ewing sarcoma, chondrosarcoma, and their variants, pleomorphic sarcoma, MFH, etc., etc. Sometimes even we have benign bone tumors, which are aggressive, locally aggressive ones like GCT, giant cell tumors, aneurysmal bone cyst, osteoblastomas. They they have a tendency to destroy part of the bone, and in such cases, we may have to go for a resection. In general principle, if it is a benign tumor, we tend to go for curettage. But sometimes when after curettage, it is not possible to reconstruct, then or the tumor is so big that it is beyond the scope of reconstruction, then we have to resect that bone. We have to take it out. Metastatic bone lesions, like I said, different organs from where the tumor may go to the bone. So few concepts needs to be understood well. When do we plan? What is the curative resection? What is palliative intent of treatment? So even in metastatic disease, suppose if you have a kidney uh, primary and it has been treated and then you see isolated lesion, then your intent is something which is curative. If it is a breast primary, you have another lesion, say on follow-up you saw after 2 years, 3 years, there is a lesion, there is a neoplastic lesion in pelvis or any other site. So isolated lesions means where you can plan for a curative intent of treatment. And also in such cases, we need to follow the basic principles of management. That is how we approach. We always have to biopsy and diagnose. Never assume in an isolated lesion because it may also be a second primary site. patients are genetically predisposed because of the various point of mutations, and they may have two primaries, which may be metachronous. Another concept in metastatic bone disease, if it is multiple, as much as possible, we try to go preserve it, because we know that disease is a metastatic. Our intent is going to be palliative. So in such cases, we go for, say, procedures like curettage or radiation. But in cases where there is a fracture, it is painful, not responding to medical management and radiotherapy, we may go for pelvic resections. Sometimes in soft tissue sarcomas, we also do hemipelvectomies, especially when there is intrapelvic extension. Last week, I did a case where there was a large gluteal soft tissue weaving sarcoma, which was insinuating into the pelvis through the sciatic notch. And it was not possible to take it out completely, so we had to do a type 1 hemipelvectomy to remove the tumor and block. So coming to the point when it is a contraindication to do limb salvage in pelvic surgery, in pelvic resections, which means when do you go for external hemipelvectomy like amputation and not an internal hemipelvectomy? So it is done in case when obvious R0 resection is not possible, or when the resection is too morbid, where you cannot plan your surgery, it's a very large tumor, then you may plan for other things. So if we divide them into different principles, so if we talk about principles, then the most important when you are not able to achieve R0, or we accept marginal resections in the pelvis, especially because of so much of critical structures, like you have vessels, you have nerve, all the viscera. So the resection may be R0 in such cases, or R1, which is acceptable and where you back it up with radiotherapy, especially in Ewing sarcoma. But when it is going to be too morbid, then probably, or it is not possible, you think that you might leave gross residual disease behind, then it's better. And if you can achieve R0 with amputation, then go for amputation. So these are few basic principles that we need to follow in our practice, surgical practice, that whenever we attempt to remove a disease, it should be done with a R0 margin, which means no microscopic residual disease, no residual disease behind. R1 resection, when you have a microscopic disease, especially when you do marginal resections, and R2 resection, which means there is gross residual disease which is left behind. So broadly looking at the conditions, when suppose the tumor is involving one of half of the pelvis and it is crossing the midline, it is crossing the sacrum. So you know that when we remove a tumor, we remove it with wide margins. And in such cases, when it is crossing the sacrum, when you resect it, you are going to damage the nerves of both the sides, and it would lead to a lot of morbidity, loss of bladder or bowel control. Patient may need a stoma in that case. So in such cases, this type of surgeries are not possible. Then you may offer them either a definitive radiation radiotherapy. Another contraindication for limb salvage, when the tumor is going inside the sciatic notch, we know that the cervical nerve roots, they join together and form the sciatic nerve, and they pass from the sciatic notch and come out through the pelvic region. So if the tumor has grown into that area, then, and it has infiltrated the sciatic nerve, then R0 is not possible. Or the other way to achieve R0 is to resect the nerve, in which case the limb would be senseless, because if you cut the sciatic nerve, there will be no sensation in the lower limb. There will be foot drop, there will be a loss of dorsiflexion. So the patient is going to have a senseless limb. In such cases, usually it is advised to go for an external hemipelvectomy. And of course, when there is involvement of major blood vessels like external iliac or internal iliac, which cannot be reconstructed, or involvement of the sciatic nerve, in such cases, we plan for external hemipelvectomy. When we have a pelvic tumor, what are the broad guidelines that we work up? So basic is X-ray. We should always get an X-ray done. Many a times the question is asked, why to do X-ray when you have a MRI or all those things? So in fact, every investigation diagnostic modality has its own advantage and disadvantages. The X-ray on one hand gives you the 2D picture in a single film. It gives you a bony architecture in a better way. It gives you the evaluation of the matrix in the tumor substance. So it helps you in planning your resection. So in this way, X-ray is the basic minimum that we should ask when we are planning uh, a pelvic surgery or any surgery, any bone cancer evaluation. Another very important investigation of evaluation is MRI. We should always ask for a contrast MRI. If it is pelvis, or say even if it is involving one part of the pelvis, you should ask for contrast MRI of the pelvis. And it gives a lot of more information than what we get from X-ray. Why do we need MRI in bone tumors? Because we know that the musculoskeletal tumors, especially the bone tumors like osteo or Ewing's, they involve uh, marrow. And marrow is best visualized with MRI. MRI also gives a good idea about the soft tissue component, the involvement of neurovascular bundle, muscles, what are the planes where we can get the margins. So all this planning can be done on the MRI. Do we routinely ask for CT scan? So if you ask me for extremity sarcoma extremity evaluation, I would be happy just with my X-ray and MRI. But once it comes to the pelvis, I ask for a CT scan often because we get a better bony architecture delineation, the cortical delineation with the CT scan. And remember that it is not just the one modality, like I'm saying. We get complete information by collaborating all the three modalities together, and so that we plan it in the best way for the management thing. Then comes your angiogram. So pelvis is a structure, it is an organ with very high vascularity. So entire lower limb vessels, right from the aorta, they come to the common iliac, then descends down into external internal iliac, and it has so many branches to the visceral organs, to the lower extremity. So angiogram gives you an idea, and especially in a tumor which has a soft tissue component, large intrapelvic component, you might well want to know which structures you are going to preserve, which you are going to sacrifice. So this gives you a good hint. If you have done a contrast MRI, so it also gives you a good evaluation about the blood vessels, how they're flowing through the tumor mass. PET scan, as such, it is a modality for staging workup in bone tumors, and in some cases, it helps in diagnosis as well. Likely, like in a large osteochondroma where a sarcomatous transformation is suspected, if we need to put up our biopsy needle, a PET scan would tell you which area has a hot uptake and you identify the right part. So this was a broad overview how we evaluate or work up pelvic case. So like I said before, hemipelvectomy are of two types. One is external hemipelvectomy, one is internal hemipelvectomy. What do we mean by this term external? Which means it is a sort of amputation. The classical terminology which was used for such hemipelvectomy was hindquarter disarticulation, which means you remove the pelvis completely. You cut your bony cut is through the sacroiliac joint and you remove the entire thing. You tie up the vessels, your iliac vessels and everything, and you remove the lower limb. Usually two approaches are done depending upon the involvement of the tumor. When it is more on the anterior aspect, then you might have to preserve your posterior gluteal flap and use it to cover it anteriorly. That is called posterior flap hemipelvectomy. And sometimes when the tumor is more on the gluteal aspect where you don't have anything to cover, then you base your flap anteriorly on the femoral vessels, and then you rotate it from anterior to posterior, that is anterior flap hemipelvectomy. This was a case which was done recently. There was a young lady, 50s young nowadays, yes. So she had a lesion in the pelvis. and which was initially she had pain and limp while walking. She had seen a local physician and she was just given painkillers and analgesics. Probably this went on for around 3 months. And when she got bedridden, she got evaluated by a surgeon where uh, it was diagnosed like there is some abnormal lesion there. And you can see here that in the pelvis, there is a joint effusion, there is a soft tissue mass. You see it on both the inner and outer aspect, and which was filling in the sciatic notch. And you can see there was destruction of the bone as well. So in this case, since the sciatic nerve was involved, it was not possible. There was contamination and there was involvement of the proximal femur as well. So we decided to go for a external hemipelvectomy. So this is uh, what we call like an amputation. The more challenging ones are internal hemipelvectomy, because here we remove the pelvis, but we preserve the lower limb. And sometimes it is really challenging. It takes hours of surgery. And I would say it is one of the most complex surgical procedures in musculoskeletal oncology. And why is it so? We'll go into the details of it. But before I proceed, I just want to see you this picture and understand that pelvis has different zones of bone. And depending upon what zones we are removing, the procedures are named accordingly. Like this is the iliac bone, this is the acetabulum, and the structure, the architecture around it is like very acetabular zone. This is the pubis, and this is the ischium. This is the sacrum. Here is the sacroiliac joint. The iliac bone attaches to the sacrum, to the sacroiliac joint. So depending upon where the tumor is located, suppose if the tumor is in the iliac bone and it is just localized, so you can resect it just only with iliac bone resection, then it is a type 1 hemipelvectomy. Sometimes when the tumor is involving the iliac bone with some overhang over the sacrum, then you might have to do iliac resection with part of the sacrum. Then it is called type 1 plus partial type 4 hemipelvectomy. Sometimes the tumor may be in the ilium and some part of the acetabulum. And when you remove both, it is type 1 plus 2. Sometimes it is only involving the pubis and you remove this part, then it is type 3. So depending upon the zone of the bone involved and resection involving that particular zone or margin leads to the nomenclature of internal hemipelvectomy. So like I said, you can see in this example, the iliac bone involving the acetabulum, type 3 ilium, ischium, and pubis. And this is the type 4. And depending upon how you remove, you have different types of defects. Like in type 1, you see here, you have a defect over the iliac bone. When it's type 2, you can see that there is defect in the periacetabular region. It may be 2A, where you remove the proximal femur en bloc. We know when we remove a tumor, there is a concept: if the tumor has involved the joint, then you have to resect it en bloc, which leads to complete resection with margins, and that is extra articular resection. We don't open the joint, you don't dislocate. Like you see here, this is the hip joint, and if there is a femoral head inside, if you dissect it out, then it is an intra-articular. But if you cut it off like this, including the proximal femur, then it is an extra-articular resection. Type 3 resections, where you remove the ischium and the pubis, and type 4 is where you remove the part of the sacrum. Yeah, of course, logically we know that both sides there are neural foramina of the sacrum and the nerve roots arise from it. So whenever we plan our surgery, we try to be just lateral to the neural foramina or to the neural foramina and preserve the nerve. But ultimately, what is important as a principle is that you should get a margin. You should not do intralesional surgery in sarcomas. Otherwise, whatever you do, the disease tends to come back. There may be some exceptions, but I don't want to go into detail of it to unnecessarily confuse. So we must remember as a gross principle, as a broad principle, that tumor should always be, the sarcomas should always be removed with wide margins. So why I'm always saying that these are the most complex and challenging surgeries? Because the pelvis is a very complex anatomy. If you see the pelvis of a male or female, so they have different visceral structures inside. You have bladder. In females, you have uterus. You have all the ligaments. You have rectum. You have intestines which float around there. You have kidney. You have bladder, the ureters. They all traverse inside in that compartment. Then you have all the important vessels and nerve. What you see here, the common iliac artery and vein. Then they divide into internal and external iliac, and then they divide into multiple small branches. So these make it very complex. You have important structures like nerves. You have the sciatic nerve. What I was telling, that it starts from the neural foramina, and then this is the sciatic notch. It goes into it, and it comes out through the sciatic foramina. Along with that, there is femoral nerve, obturator nerve, which are in the intrapelvic side. So it's a complex anatomy which comprises of multiple vessels, important nerves, all the important viscera, which, if damaged inadvertently or if which are sacrificed as margin, can lead to a significant morbidity. And when there is a large tumor inside and you need to take a margin, many times you have to uh, resect them out, and you have to sacrifice them as margin, which leads to a lot of morbidity, blood loss. The exposure is not that great as it looks in these pictures. When you go inside, and if there is a tumor inside the cavity, it obscures your vision. Many a times when we have to resect, we have to take blind cuts based on our judgment. Nowadays, we have many advancements, especially with the help of 3D reconstruction of various implants and zigs. Exactly tumor replica can be made, and we plan the zigs so that even the cuts are not visualized, we can make the cut through it. We have computer navigation with us, which helps in precisely identifying the points from where we need to make the cuts. So all these processes have made these pelvic surgeries much more amenable. And nowadays we see good results, the clinical outcomes, oncological and functional outcomes, with the help of these modern technologies. So like I said, when we plan for a surgical planning, very important aspects we have to see. So just to highlight them, like the iliac vessels, are they involved or not? We always have to protect the ureter. So what commonly as a surgeon we do that, in my practice, we commonly, if there is a large intrapelvic tumor, we put ureteric catheterization so that intraoperatively we can feel it. Because if we cannot see, we are taking the cuts, there's a high probability of damage. So when the catheter is inside the ureter, you can feel and we can identify and localize that. Sciatic nerve is very important, that we need to preserve it. So that's why I said when it is infiltrated or when the tumor is into the sciatic notch from where the nerve exits, it becomes a case for an amputation. And of course, bowel and bladder, you have to preserve. Most of the times, our approach is retroperitoneal, and we use utilitarian incision. My suggestions to all the residents who are listening, that few books are basics. You must read them if you are ever planning for a surgery or you want to understand much more about hemipelvectomy. And Malabar is one of them. Then you have Master's Technique in Orthopaedic Oncology. So these books have very nice diagrams, and many of the pictures I've taken from there also for better understanding. Then, of course, very important is about which bones are involved, and what, when you are taking the margin, whether the resection is going to involve the other bone also. Like I said, if it is involving part of the ilium and you need to take some margin, it's not that if it is iliac bone, then you just cut off the iliac bone. You need to take a margin beyond that, and it may lead to resection of even acetabulum. So you need to plan it very well. And this is something which is not a single man's job. We need to work it out with a team. Most of the times, I have a surgical oncologist along with me when I plan for pelvic resections, and it is work as a team that we identify all the viscera. Uh, we go in together, we protect all the vessels, identify the extent of the tumor, correlate it with our preoperative planning, and then accordingly we make the cuts. Because of non-visualization of internal structure, sometimes the bleeding is there and you have to be really careful. You have to go in with all the backups with the blood bank. You have to reserve adequate amount of blood, uh, fresh frozen plasmas, platelets, RDPs or SDP, depending upon the type of resection, what you are doing, depending upon how big the tumor is, depending upon how vascular the tumor is. So there is a lot to discuss on that, but I thought it's better if I go in with few examples, which are my own cases, so that you can understand better. So, like I said, that type 1 iliac bone resections, which involves resection of the ilium. So this was a young gentleman who presented to me almost, I think, 3 years back, where he was initially seen in a cancer institute, in a government cancer institute. And first time when he had seen me, there was a lesion which was only involving part of the iliac bone. But then he came for opinion. He went back for surgery, but surgery was not done for 3-4 months. He was in a queue. And when he presented to me again after 4 months, the disease had reached tremendously. And you can see that one side of the ileum is destroyed. There is a margin. You can see there is a sclerotic margin there. You can see the soft tissue component, which is reaching up to the lower part of the ribs. You see there's a large stone formation, which was the back, because of the back pressure on the kidneys, on the ureter. There was a stone formation there. And that time he wanted me to operate. The diagnosis was giant cell tumor. And if you see the imaging, you can see there are dilated veins on the abdomen. He had a tilt of the pelvis because of this large tumor. And when I put my hand on for palpation, I could feel the warmth. So it was a very vascular tumor, and GCTs, the giant cell tumors, have a lot of vascularity. In such cases, if we operate, these are really challenging ones, and sometimes if there is bleeding, even there are chances of perioperative mortality because of the hemorrhage. So we decided, since it was a giant cell tumor, I decided to use Denosumab in this case. Denosumab is a monoclonal rank ligand inhibitor, uh, and we gave patient around 9 doses, and you can see the response that the tumor, which was highly vascular and composed of mainly the soft tissues and the vascularity, started ossifying. And when we felt that it was adequately ossified, then we planned for the surgery. And it was not a simple surgery because we wanted to preserve the hip joint. A 3D planning was done that we take the cut in such a way that we do not damage the hip joint. So this is what is the utilitarian incision is, where you start your mark the anatomical landmarks. You mark your pubis, you mark your ASIS, anterior superior iliac spine. Your incision runs from your ASIS to the pubic tubercle and posteriorly around the PSIS to the sacroiliac joint, which is felt like a dimple there. Many times we have to put an extended incision down here for better exposure, but I prefer to use just a single incision because this T-shaped incision many a times leads to breakdown of the skin at this point. So we went in with the same approach. You can see here the tumor was so much on the medial aspect that we had to extend, in fact, not on the outer aspect, but we had to extend our incision towards the umbilicus to expose it completely. And if you see, these are the main iliac vessels which are there. And we dissected the ileum. And this was the specimen which was taken out. So if we look at the post-operative X-ray, this is the catheter in situ, which was removed later on. It helped a lot in preventing damage because with such a large intrapelvic component, it is not possible to visualize. Uh, you have to dissect and you have to take your cuts based on your instincts, experience, and your practice. And and we don't want to do any damage to the patient. So so we take all the precautions, and this is what you see. This is a type 1 type of hemipelvectomies. And here we could preserve the hip joint. Normally, do we do any reconstruction here? So there are attachment of the gluteal muscles, especially gluteus maximus, medius, and minimus. And as a margin, wherever you remove them, then there is a limp or lurch while walking. But if the patient is well trained and is under supervised physiotherapy, they do very well. Normally, after type 1 hemipelvectomy, we don't need to reconstruct any bony structure. Soft tissues we can interpose and to give them sturdy. So this is almost 1 year after the procedure. Patient is independent ambulator, is able to do all active exercises. Yes, he has hernia there, which I have told not to uh, do anything for it at present. Let us first get some time and then we'll do anything for that. Coming to type 2 resections, we know type 2 are like periacetabular resections, where you resect the acetabulum or part of it. So this was another old lady, 65-year-old, and she had a sarcoma of the left hemipelvis. She had received chemotherapy before, and you can see that this is the part of the iliac bone, which is also destroyed, and this is the part of the acetabulum, which is destroyed. You can see in the imaging that there is a soft tissue component on the gluteal aspect as well as some soft tissue component on the uh, intrapelvic side. We did a fine planning. Of course, it is not possible to share all the images, but for understanding, the tumor was involving not complete acetabulum. It was involving part of the acetabulum. You can see the superior, superior aspect, which is the supraacetabular zone. And it is important, acetabulum has a very important role because the hip joint during weight bearing, during walking, the hip joint, the femoral head, it sits over that area and it prevents further migration of the femoral head. But in this case, we have to remove this part. And if we remove it completely, the morbidity is going to be much more. So we tried something which is a partial type of type 2 hemipelvectomy. In this case, what I planned that we will remove type 1 iliac resection as well as we remove part of the acetabulum, but we preserve the lower part of the acetabulum. So you can see here, in this case, like we have resected here. This is the femoral head. You see the main iliac vessels, which are isolated and protected. Then you have the femoral nerve. So femoral nerve runs between the iliacus and the psoas on the uh, inner aspect of the pelvis. And then it is, we have removed majority part of the supraacetabular region, but the inferior portion of the acetabulum was kept preserved. This is the specimen, what we see. And then how to reconstruct. Here I have used a mesh. This is a polypropylene mesh, which is commonly used for hernia repair. And this has been extensively used in our practice, where since there is no bony support superiorly, so we tie this up with the head and the remaining part of the acetabulum, so it acts as a barrier for the further migration. Of course, it requires a dedicated rehabilitation protocol where we need to give time for the fibrosis and healing of the lesion. And in this case, usually for 6 weeks, the patient is non-weight bearing, and then slowly we start mobilization. Once this heals, this mesh heals, it causes a firm fibrosis all around and prevents migration of the hip joint upwards. So there is some shortening, some lurching, but not as significant when we remove it completely. The acetabulum is completely removed. So here you see this was the preoperative X-ray, and you could see the extent of the bone involved, the disease involved, and how we have removed part of the iliac bone, and this is the part of the sacrum, that part of the acetabulum that is removed. So there are different, this is also a question like what are the reconstruction modalities after type 2 hemipelvectomies? So we know out of all these, like type 1 iliac resection, usually you don't need any reconstruction. Type 3, where pubis or the ischium is removed, it can be left as such because the acetabulum supports the head. But type 2 is one of the most challenging case scenarios where we need to give some sort of stability, some sort of support for the femoral head. Otherwise, the patient will not be able to walk or will be able to walk with a lot of morbidity or will be dependent upon some support lifelong. So there are different modalities that has been discussed. Most commonly what we do is a mesh repair like what I had shown you in the last case. In this case, usually it forms a pseudo-arthrosis type. When the acetabulum is not there, it's a mesh. It forms a pseudo-arthrosis type of joint. And in the patient, once there is some mobility, it migrates a little bit up, but has stability. Patient is able to squat, sit, and it's pain-free type of unrestricted movements. Other type is if you have removed the acetabulum, then the remaining part of the femoral is attached to the iliac bone superiorly, or even it can be attached to the ischium, ischiofemoral or iliofemoral type of arthrodesis. Some of the recent modalities where we resect the part of the acetabulum, we reimplant it after sterilization. It can be reimplanted after extracorporeal radiotherapy, which is a common procedure we use in orthopedic oncology. We sterilize the bone after radiating with 50 gray in a single fraction, put it back, fix it. Of course, it is not that easy as it sounds like, because the chances of non-union infection, complications, cartilage wear and tear, it may happen over the time. But once, if you can use that, then it is a very good modality to restore your normal congruity of the joint. Then we have prosthesis reconstruction. There are different types of prosthesis. We have saddle prosthesis, bone prosthesis, customized prosthesis are being made nowadays, where you can reconstruct the femoral head, the acetabulum cup, and the femoral head with the prosthesis, and the patient can be mobilized. In our experience in Indian scenarios, prosthetic reconstruction is not that commonly used. The most common technique what is being used is the mesh repair, which gives a very functional hip joint movements. The prosthesis looks good, looks lucrative, but they have their own complication risk, especially because you know that in the pelvis, a lot of musculature is removed when you remove a tumor, and then if there is a chance of infection or complication, that may have to be removed. There are different studies which have shown that from 30 to 50% of the cases have some complications for which it has to be secondly revised or removed, or patient had to undergo amputation. So just to show you with some examples, this is what is the saddle prosthesis, which fits inside, and then you have this arthrodesis, and this is like a customized implant which is made where you make a hip, and with the acetabulum cup and socket, you replace this entire component. The type 3 resections, which involve pubis and the ischium, usually it does not require a reconstruction, skeletal type of reconstruction, and patients do well. Sometimes we do a combination of all of them when there is a large tumor. Like this was a case, which was my first case when I joined in a private setup. And this was a young boy who had osteosarcoma, which was involving the pubis and ilium and the acetabulum part. So you can see here on the X-ray, which shows some aspects regarding the ossification, but you see the real picture, the soft tissue component, the involvement, everything on the MRI. And also you see here, this joint was involved. Patient had painful clinically. You can make it out whether there is involvement of the joint or not. On rotatory movements, patient had painful hip range of motion. Here also the disease was crossing the midline of the pubic symphysis. So it was a major type of resection where we had to remove type 1, 2, 3, and in fact, it was a extended type where we had type 4, where we had to remove a part of the sacrum. Because the sacroiliac joint is not a straight uniplanar type of joint where you can just make a straight cut. But if you see, if it is a sacrum, the iliac bone is overhanging. So from inside, you have to take oblique cuts, which is not always possible, and you may leave a positive tumor inside. So in those scenarios, what we do, if it is the sacrum, rather than going through this, we make a cut uh, on this area so that the entire sacrum and the overhang of the iliac portion is also removed. So in this case, we isolated all the major neurovascular bundle. And if you see this with this pelvic model, you see here the femoral head, which is still in situ. It was an extra-articular type of resection, which was done. And this is now more than 4 years after the surgery. So in this case, the proximal femur part was anchored to the sacrum with the help of mesh like we use. And you see here, our cuts was on the opposite side of the pelvis, on the pubic and the ischial bone. So the patient is now disease-free for 4 years. He's able to walk. Of course, he has to use a stick for walking, but he is living an independent life. So I would say that hemipelvectomies are the most complex and challenging case to handle. And if we talk about the different type of resections, type 1 resection usually do not require any skeletal reconstruction. Type 2 requires reconstruction to restore the function of the hip and to give stability. And depending upon your experience, expertise, and the availability, you may use the different options which has been discussed. Type 3, usually no reconstruction required. And most importantly, the pelvic resections require a multi-modality, a multidisciplinary approach. When we deal with a tumor, when we deal with a sarcoma, the surgical aspect is the last. We have to start with the right diagnosis. We have to approach the tumor completely with the right protocols so that we do not miss out. We do not underdiagnose a sarcoma. We do not overdiagnose a benign aggressive lesion, which may ultimately lead to bigger resections, more morbid surgeries. For that, always correlate clinically, radiologically, and then do a biopsy to confirm. Once you have done that, do a staging workup, see whether it is a localized disease or it is systemic disease. Then comes your treatment. Whenever it is required, plan for based on the histopathology. You may need to give chemotherapy or radiotherapy or surgery, depending upon the modality. You have to use judicially your armamentarium. So thank you very much. And I hope this gives you an overall view about the pelvic resections. And I would say that if you have any doubt, any query, feel free to text me or WhatsApp me for any query if you have.
Thank you so much, sir. You explaining such a manner because not being a surgeon, also I got most of the points that you explained. All the T1, T2, T3 resections. Uh, so it's wonderful, sir.
Great.
So, uh,
Thank you. No, so
so if there are any questions,
if I'm able to convey that to a radiation oncologist, then I think my work is done. Uh, and these are mainly a surgical domain type of tumors involving the pelvis. But many a times, and in fact, the indication of radiation is very high, especially in Ewing sarcoma of the pelvis. And nowadays, when there is a component, usually we give preoperative RT followed by surgery to sterilize the margins to make the resection better. So it depends upon case-to-case basis. And I think a lot can be discussed on this topic. But I think it is a great job that we are doing that. Very specific points are being discussed for the educational purpose, and I think students and even practitioners will benefit from these talks.
Certainly, sir. So